finally, let me introduce you to today's speaker. You may remember her if you attended our harm reduction webinar or part one of this training, and that is Mira Corey. And she is a coordinator with the Maryland Harm Reduction Training Institute. Ms. Corey is a Morgan State University graduate with a bachelor's degree in psychology. She has 6 years of experience with the Lighthouse Studies at Pierpoint and B Shore, which are 2 harm reduction research programs through Johns Hopkins University. They focus on Baltimore City residents with HIV, STD, high-risk behaviors. Before joining Behavioral Health System Baltimore, Mira was the evaluation coordinator for wraparound systems of care and the National Child Traumatic Stress Initiative. These are all programs at the Institute for Innovation and Implementation, which is a part of here at University of Maryland, Baltimore. So welcome again, Mira, and thank you for joining us.
Thank you so much for having me. I am glad to be back and be with you all. And are we ready for me to begin? Should I start sharing my screen now?
Yep, all of yours.
Thank you. Alrighty, and just really quick, just making sure that everyone can see my screen.
Yes, I can see it.
Okay, great. Sorry, I hid your photos, so I couldn't see if you were doing a thumbs up. So good afternoon, everyone, or if you are on the West Coast, good morning. As Tiffany stated, my name is Mira Corey, and I am representing the Maryland Harm Reduction Training Institute. And this is the second part of our Stigma, Trauma, and People Who Use Drugs training. The first part was held last week on the 13th. And just to briefly go over some of the things that we went over before. So here are the objectives of today's training. So by the end of today, you should be able to understand stigma and the impact it has on people who use drugs, understand how trauma and racial injustice have impacted communities, understand how to respond to stigma in the workplace. And the agenda for today is to further define stigma and its impact on people who use drugs, the science behind stigma, history of drug criminalization in America, and then we're going to have some time for questions and wrap up. And as I said before, this is typically a 3-hour training, and we just broke it into 2 parts to better allow for time. So I just want to do a quick recap about the components of stigma. Okay, so this is a slide from our previous training, and this is how we define stigma, and it's defined by the co-occurrence of these 5 components: labeling, stereotyping, separation from the non-stigmatized, the status loss as a result of the labeling, stereotyping, and separation from the non-stigmatized, and then discrimination, which is perpetuated by the non-stigmatized with by the greater access to social, economic, political power, and that is how the manifestation of the discrimination that we see, right? That's what it looks like. And these things, they further indicate that for stigmatization to occur, power must be exercised, right? So you have to have or have to create an environment for there to be a power imbalance so that one population is viewed as the upper echelon, the higher than the other. And this hand, the higher folks, are the ones that are stigmatizing and demoralizing the lesser. Okay. And we see this all throughout civilization. And we talked about this a lot in our previous session, talking about the racial implications of stigmatization and how that affects people who use drugs, how, the war on drugs, how much of a racial implication that there is, how many levels, how deep it goes, right? Again, I talked about it a lot because it sticks out in my mind. The Ehrlichman admission about the government, the Nixon administration knowing what they were doing to blacks, browns, hippies, whomever, right? They were doing it willingly, viciously, maliciously, every night to villainize, to destabilize populations. Okay. So again, we're going to delve deeper. Unfortunately, this session doesn't have really any video clips, and we're just going to have to kind of talk it out and listen to me talk. I'm sorry. But hopefully you'll find this as enjoyable. So I want to give folks just a brief moment to do like a little group brainstorm. Thinking about your work environment, what are some challenges that you've encountered in your work due to drug-related stigma? And you can put them in the chat, or you can take yourself off of mute. I'm just going to do this for like a couple, about a minute or less. Okay. Okay. So no one goes to the library but drug addicts is what I'm seeing. Opinions, people's opinions, you know, community needs I'm seeing, not taking people's pain management needs seriously, uh, you know, hiring issues with hiring folks with lived experience, all of those, right? So yeah, those are some things that you see related to stigma, right? To in your workplace. And I ask this because as people who are working in potentially in healthcare professions, because even though, we don't think about it, well, let me back up. Most people do not cognizantly think that they work with, service, however you want to put it, people who use drugs, right? But we know that there are more people in this world who are, experiencing substance use disorders or chaotic use with substances or, somewhat problematic. That population is greater than we thought in the sense that more people are coming in contact. And so people need to be aware of how these challenges and these stigmas affect them, even when you're not in a occupation that frontwardly thinks, oh, I'm working with people who may use drugs. And people like ourselves who work in the healthcare community, or those who work in law enforcement, we see folks every day, all day, with these, situations. But that doesn't mean that our stigma goes away. It doesn't mean that our institutional or our occupational, structural stigmas go away. And we see them show up in different ways when we're trying to do our job, right? So, for example, someone mentioned not taking people's pain seriously. That is a stigma. If someone comes into you with fresh track marks, but then they have like a severely sprained ankle, someone in the ER might look at those track marks and say, man, they're not in that much pain. Like, they couldn't be. How could they? They do whatever. Just give them some Tylenol. Mind you, that severe sprain might actually be something broken, and they are in that pain. Listen to people, not view them through their actions or the activities they choose. Okay? So, going back to some of the things that we talked about before, we're talking about the different types of stigma, the 4 eyes of oppression, if you will. So we have the ideological oppression, we have the institutional oppression, we have interpersonal oppression, and we have internalized oppression, right? Notice how other than the ideological, really, everything starts with institutional, interpersonal, internalized, which means it starts from the inside and proliferates outward, right? So you come with the ideological, people who use drugs are bad. Then we take that ideology and we institutionalize it. So we villainize people on the evening news night after night and disrupt their communities. And then everyone that we broadcast to, it goes inside their brain. Now they interpersonally, now they've drafted onto that ideological thought. Interpersonally, now when they're having conversation, I don't hang out with Jackie anymore because, Jackie does that stuff. And we know about people who do that stuff, right? Well, then Jackie has had months, years, decades of being put to the side because of how she's living her life. Now she internalizes that vitriol, that shame, what have you. So now it's internalized. So now the people who don't want to hang out with Jackie don't need to even tell Jackie how they feel, because now Jackie feels about herself the way the ideology, the institutional structure, and the interpersonal societies feel about Jackie. And then she can now take that and say, you know what? I may do this, but I don't do that. And that makes me better than them. And that is an internalized stigma and framework. And so now the people who created the ideology, now they don't have to do any of the work. They've done it all, right? Now we as society, as the masses, we just go out and push their message. That's how it works. That is exactly how it works. It is the greatest pyramid scheme we have ever created. Think about it that way, right? This is the type of thing that Mary Kay and Madoff, that they would dream of. If they could just graft into this on the masses, it'd be wonderful. But yes. So again, we saw this slide last time we were here, and I wanted to bring this back up because I want you all to keep thinking and keep remembering that it is so much bigger than just what you see in front of you when it comes to stigma, right? Like there's so many layers above it, below it, beside it. And I just want to, keep you rooted in the facts of it, or the basis. I'm just checking the chat really quick. Okay. So what I want to talk to you next is about what leads us, can lead people down the road, somewhat traveled. I would not say less traveled, but somewhat traveled, to substance use and potentially bad outcomes, right? So let's talk about ACEs. ACEs stands for Adverse Childhood Experiences. Okay. Now, some of you may have heard of this. It was created by Dr. Anda. And so ACEs, or Adverse Childhood Experiences, are these traumatic events that happen in a person's life, particularly in their formative years, so childhood. And seeing these things, what impacts it has on a person's future, or what it could look like for the future. So let's talk about what ACEs are. So we have, 3 big domains, which are abuse, neglect, and household dysfunction. So when we're talking about abuse, we're talking about physical abuse, emotional abuse, and sexual abuse, right? When we're talking about neglect, we are talking about physical neglect and emotional neglect. When we are talking about household dysfunction, we are talking about mental illness being in the household. So typically someone, whether it be a parent, or older sibling, or even younger sibling, depending, if the mother was treated violently, so seeing domestic violence, or I am definitely of the fair-minded sense, any sort of domestic violence situation. So that means if Jackie has a mom and a dad, 2 moms, 2 dads, what have you, if someone is beating on someone, that is a traumatic event, right? Divorce or separation, also traumatic, or can be part of the ACEs. An incarcerated relative, and also particularly parental substance use. This was taken from another medical. This graphic was taken from a different medical journal. I do not like the term abuse, which is why I personally say use, but that's why the graphic says abuse. I just want to make that clear. So these are all things that can contribute to adverse childhood experiences. And people can have experienced none of these, could have experienced one of these, or all of these. And these domains and experiences were taken from a study. And these were things that Dr. Anda and his group were seeing across the patient demographics, right? Participant demographics. So all of these some may seem super, heavy and weighty, and some may seem like, it happens every day, i.e. divorce or separation, right? So that's how some people think of things. But even if that is how you think of things, they are still traumatic to people, right? Always be mindful. So let's talk about how these ACEs impact people, and how this goes into stigma and what people who use drugs face. So when we're talking about ACEs, I like to call it a pair of ACEs. So when we were talking before, we were talking about adverse childhood experiences, and these are things that happen in the home or happen directly to a person or in a person's direct ecosystem is how I like to put it. The other side of ACEs, or the other part of the pair, is what's considered adverse community environments. So there's poverty, discrimination, community disruption, lack of opportunity, economic mobility and social capital, poor housing quality and affordability, and violence. As you hear the sirens in the background, sounds a lot like Baltimore City, don't it? East Side, Lafayette. If you are of a certain age, in my Perkins Homes, Murphy Homes, Whitelock, Park Heights, which is where I spent the last 20 years, right? You see all of these things. Abandonments downtown, Once my dad said, parts of Baltimore City looks like a kid with a bad sugar habit, just broken teeth every couple spots. And then when it's not that, it'll be a gap. And then you have a tooth, aka a livable home. All right. But as you can see from this graphic, notice how it is the roots, aka the adverse community environments, how the roots of those things grow into the tree that is adverse childhood experiences. And I'm going to go ahead and I'm just going to lay it all out for you. If your community is impoverished, if it has been disrupted, if there is a lack of economic mobility, opportunity, the housing choices are poor, you're going to get what? Violence. You're going to get discrimination from people who don't live in that neighborhood. And what is that going to breed? Because that's that social, that structural, we're going to internalize that, right? We're going to internalize that as a community, but also as an individual. And when we internalize that, but we're in a place where we're feeling powerless, we take that to the only place where we can exude power, which is our own home base, right? Because in our home, for the most part, we run that show. So when the poverty and discrimination and all of that, all of the adverse community environments, ACEs, reach that critical mass, we take it at home. And what does that look like at home? That could look like domestic violence. I can't hit my boss, but I can exert my frustration on my family. Maybe we don't want to take that route. You know what? Maybe I'm going to further internalize it, and I'm going to turn to drugs or alcohol because I need an outlet. Or maybe it's too much, and maybe my partner and I are both feeling it, and now we can't seem to make it work, so now we need a divorce. Or we are fighting tooth and nail to get up above these community roots, but we still wound up homeless. And my oldest child wound up incarcerated because he was robbing, trying to get money to help us out of poverty. And now he's incarcerated. and my baby child has seen all of that. Okay? That is what ACEs can look like. These are the roots and the tree of what we see every day. And then now that you and seeing that, right? Seeing these roots, seeing what is nourishing the damaging food that is nourishing this toxic tree. Now we have people villainizing the fruits of that tree, aka the people who are eating off of this maternal depression and poverty root system, tree system. And we're self-soothing with our substance use or our physical or emotional neglect or however, but we're now villainizing them every day, particularly those who use substances every day on the news, with the carceral system, punitively with jobs. But nobody's asking if they're okay. Nobody's trying to see, well, what if we clear up some of these things? Would the leaves start to fall off? We're not thinking about that. As a society, it is easier to demonize and villainize every single day, like the Nixon era told us. And he did say he wasn't a crook. He didn't say other things about himself. We did. I want to pause for a quick moment because I feel like, at least for me, that was a little heavy. So I want to check in with folks. I'm going to check the chat, or if you have something to say, please feel free to take yourself off of mute. Anyone? No? Good.
So far, no questions. Or
Cool.
someone did say those homes are also more heavily policed by Child Protective Services.
Correct. Exactly. Yes. Yes. Imagine having all of these roots down here at the bottom, winding up homeless, but now you are in a home, maybe it's a homeless shelter, or maybe it is a subsidized housing. But all these things are still happening, right? Because you just barely got your feet up under you. So we haven't even had a chance to address the domestic violence or the substance use. And so you're still self-soothing. And now, the Housing First people or the CPS people, they happen to catch you on a bad day. Maybe you didn't clean up your works quick enough because it was a surprise visit, right? Now you're penalized, and now you are going to be kicked out and sent right back to where you scraped and saved and clawed your way to just get barely where everyone else is, and raked back down. That's what we're fighting. That's what our people are fighting. That is what we as harm reductionists are fighting on the systemic level, right? And this is what our people are fighting every day. That is why when they come into you, they got their back up. Some of them are angry, so angry. It comes off so just, and it seems like it's directed at you. And honestly, it's not. It is directed at the systems that have oppressed them, that you, standing in front of them, unfortunately represent, right? I am seeing, we already said earlier, and I saw in the chat, people who working in hospitals are, having people say, oh, well, nobody believed me. Or we hear on the news, oh, yeah, well, they were homeless, came in talking about a heart attack that they might have been having, but we just let them sit there for 6 hours because, they were homeless and they used drugs and they were probably just BSing. Now the person is deceased or in a coma, right? These are things people hear. These are things people see. Like, this is not, for us, it may be something that we just hear on the news every now and then. The people that we serve, this is their everyday. This is someone that they know. This is their friend. This is their partner. This is their sister. This is their mother. That person you hear about on the news and you're just like, oh, I can't believe a hospital would do that. They do. Often. And that person belongs to someone. Yeah. Yeah. So I just want folks to take that in so that when people are coming to you angry, it is not always about you. And they're not always angry. They are scared. They are traumatized. They are broken. And the only way that they know how to exert any sort of control over a situation when they are terrified out of their minds that they're going to be judged is to be angry. So that actually made me get a little teary-eyed. So sorry about that. But hey, if I don't feel anything for my folks, then I'm not doing my job. So ACEs and substance use. Why did I spend so much time talking about ACEs? Why am I trying to make that stick? So again, the ACEs are things that, with the exception of abuse and neglect, but even still with abuse and neglect, these are things that we see every day, that we take for granted, that some things we say, oh, or let me help you. But in general, these are everyday things that we see that impact people surfacely and deeply. And what does that look like for people? How does that show up? So in 2014, Dr. Anda and Dr. Clemente and a whole group of doctoral buds, as I would say, they had this study. And so looking at their population and looking at those ACEs domains, 33% of the people who they studied reported no ACEs. So none of those things happened to them. There was no neglect, no abuse, and no household dysfunction. With 0 adverse childhood experiences, 33% of those people state only 1 in 16 would smoke, only 1 in 69 would be an alcoholic, only about 1 in 480 used drugs intravenously, and about 1 in 96 attempts suicide. Okay. Now, about 51% of those study participants stated having 1 to 3 ACEs in their history. All right. So thinking about the high end, folks with about 3 ACEs, about 1 in 9 smokes. So that is a significant increase in negative health outcomes. About 1 in 9 is an alcoholic or has alcohol use disorders. 1 in 43 has used or was using IV drug use. 1 in 10 attempted or had some sort of suicide attempt. That's just from going from 0 ACEs to 3. And that is not, that doesn't mean that the ACEs of those 3, the 3 ACEs that were cataloged were what many would consider the harshest, meaning the sexual, physical abuse or physical neglect, right? It could be divorce, and it could be, an incarceration, or, something about just general household dysfunction that we have normalized, which again, and I say we normalize because we no longer see them as a dysfunction. We see that it's become so apparent, so common that people are just like, who doesn't go through a divorce? A lot of people don't. And it's traumatizing even still. Now, about 16% of the study participants reported having 4 to 8 ACEs in their past. A participant with 7 or more ACEs has significantly, like it has ratcheted up even from 3 ACEs significantly. So a person with 7 ACEs, about 1 in 6 smoke, about 1 in 6 has a problematic relationship with alcohol, about 1 in 30 uses drugs intravenously, and 1 in 5 has attempted suicide. We went from 1 in 96 to 1 in 5 potentially attempting suicide. That is what these things could potentially bring forth, right? It is not a guaranteed. So I'm not saying, so anybody who is thinking about their past and so on and so forth, don't freak out. Don't freak out. That doesn't mean that this is a guaranteed. It means that there is a direct correlation or a strong correlation that if you have these things, you are more likely to experience these things in your future if these things are in your past. And these are negative health outcomes. And I need you to understand that when the original ACE study was done by DiClemente back in 1995, they weren't thinking about substance abuse. The ACEs came about because they were trying to figure out why people were overweight. And as a plumpkin myself, I started saying, thinking about my own history. And I was like, oh, maybe that's why chocolate cake is extra delicious for me. Right? But that's what it was. They were trying to figure out, Dr. Clemente, they were trying to figure out why people were overweight. And so they started taking histories of people, and then they found out all of these other things. They found out all of these other things that were in people's past. But then they were also seeing all of the other things that were happening, the health issues that they were having right then and there, and how the two came to be, right? Well, why'd you start smoking? I mean, well, my parents my parents divorced when I was 9. I had my first cigarette at 11. Huh, interesting. That's what, that's how Clemente and such were looking at it like, wait, what? that was a watershed moment for them, if you will. Okay. So the impact of trauma. So now that we know that Yes, thank you, Aaron. Thank you for the assist. Excellent. I saw that citation. I love it. Reenactment. So these are the impacts of trauma, and we have heard about these through time. This information, I'm sure you have seen more than once, but I want to talk about it. So the impacts of trauma. So reenactment, repeating your history. So if you saw it in your house, you may repeat it in your own household as an adult. Trauma survivors can develop a loss of a sense of self-worth, right? And which is interesting because sometimes that can fluctuate between these grandiose, overinflated senses of importance, which people think, oh, they think they're so big, but it's really just a protective measure because they don't feel the self-worth at all. So they make it up. There's a loss of sense of self when someone has experienced traumatic incidents. There's a loss of physical connection to the body. You may see dissociation, like they are disconnected from themselves. And that could look a lot of different ways. Like, I don't know if you've ever talked to someone who may have had a traumatic life and they say, oh, I don't remember anything between the ages of 8 and 12. That is 4 years of someone's life that trauma has dissociated and clouded over because it was too much for their brain and their body to store. So they're just like, yeah, we're going to wipe that hard drive. I mean, it's still in there, but we're going to wipe that. Loss of intimacy. Trauma survivors can have a hard sense of feeling intimate with someone. And it's not just sexual. Intimacy, it covers so many levels. But you need to be secure and feel secure to have any sort of intimacy with anyone, friendship, or in a sexual loving relationship. Another huge impact of trauma is shame, right? Shame, a deep-rooted sense of shame. Then we have loss of trust. And if there is no trust, you cannot develop intimacy. If there's no sense of security. People who have experienced trauma may have lost a sense of danger cues. So what that may look like is that little meme of the cartoon dog having a cup of coffee and it's all flames. And the caption is, "This is fine. This is fine." That's because the dog has no danger cues, because they've been in fight or flight for so long that when the house is on fire, a house on fire feels normal. Gonna sit here and drink my coffee. Maybe, might even roast a marshmallow in that flame over there. But a minor inconvenience, like I lost my car keys before I was supposed to walk out the door, is a complete meltdown. That's what trauma looks like. House on fire, cool as a cucumber. Can't find my driver's license, or the panic of at midnight, where is my birth certificate? I don't need it for anything, and I'm clearly alive. But the trauma will wake you up in the middle of the night. Loss of safety. And it looks like a little point on here because it's just like a little thing, but a loss of safety is huge. If you do not feel safe anywhere, in your home, out of your home, in your own skin, how can you alleviate that? It's like being allergic to wool, but you are wool, right? That is what people are feeling. And that is what leads people down a way to self-soothe, because they want that itchy feeling gone. They want that feeling of not being comfortable and safe in their own body gone. And the easiest way to do that is to not feel that. Okay. So, I keep trying to move the wrong thing. Okay. So, challenging stigma. So, the differences between traditional, trauma-informed, and healing-informed. So, traditional care, the question is always, what's wrong with them? What's wrong with them? Why do they act like that? Why do they do that? Right? Trauma-informed says, well, what happened to them? What happened to them that is eliciting this reaction? Where healing-centered care, the question is, what's right with them? It takes the trauma-informed piece and turns it a bit. So it is strengths-based. So we can take the trauma-informed approach and say, well, what happened to them? Okay, they were abused as a child. That is a trauma-informed approach, and that can help. But when we switch it to the healing thing, the healing-centered approach, the thought is, I know Jackie was abused as a child. So what's right with them? Well, Jackie can walk into a room and mentally do a vibe check and say, I should probably stay away from Johnny over there. He seems like a manipulator. Or I don't want to talk to Kiara because I can already tell she has boundary issues and I don't like that. And she's going to trigger me. So Jackie can walk in, due to her trauma response, can walk into a room and read the room for herself as to who she should align herself with and who may make her feel safe. That's what's right with Jackie. Because I'm going to go ahead and go out on a limb and say Jackie is right. Probably about 8 out of 10 times. Because her trauma and what happened to her has altered her brain to think, I need to find safety and security in my environment. And so we need to uplift that healing-centered thought and use it and have it work better hand in hand with trauma-informed. Because if we stay trauma-informed, we're still just looking at it as, oh, well, Jackie uses drugs because she was abused. And so it starts to be, well, Jackie was abused. So, X, Y, and Z. Well, Jackie can't eat potatoes because she was abused and such, right? It winds up being what happened to Jackie as opposed to seeing Jackie. You have to start in a trauma-informed place, but you have to move to a healing-centered place, because staying in a trauma-focused place keeps people rooted in trauma. You want to acknowledge it, but you also want to help them heal. And you want to acknowledge the things that they have done, the coping mechanisms that they have done to help them heal. Some of them may not be helpful. So like I said, self-soothing with substances, it is helpful to them. It may not be helpful to the program that they're in, right? Especially if it's a zero tolerance policy. But knowing that will help you get to the healing part. So person-centered language. I've said it, you've heard it, you've used it, but let's talk about it a little bit. What it is, person-centered language is a language that puts people first. right? Seems simple. People are so much more than their substance use disorder. They are so much more than their mental illness. They are so much more than their disability. Using person-centered language is about respecting the dignity, worth, and unique qualities and strengths of each and every individual. A person's identity and self-image are closely linked to the words used to describe them. So people who use substances and alcohol in chaotic fashion or have a substance use disorder are the only, well, one of the main groups of people who are described first by the action that they do as opposed to who they are, right? So what does that look like? That looks like, oh, you mean Jackie, the insert pejorative term. It's not, oh, Jackie, she's really cool, da, 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 and sometimes such such. It is the first thing. It's like Jackie and her, whatever that is. Nothing, no one else does that. No one walks into a room and be like, there's that cartoonist, Andy. So all he does is doodle cartoons. Nobody looks at cartoonists like that. Unless it's ventriloquists and people seem to feel a little weird about them. But I digress. That's right. Darn cartoonist, Rebecca, I swear. Menaces. So, challenging stigma and why language matters. Why do we harp on this so much? People with substance use disorders are viewed negatively, more negatively than those with physical or psychiatric disabilities. Even among highly trained substance use disorder and mental health clinicians who are significantly more likely to assign blame and prefer more punitive, i.e. jail sentences, versus therapeutic responses when case vignettes use the words substance abuser rather than person with substance use disorder. So when you use stigmatizing language, when you start with using negative language, you have already set the connotation for your mental processes and how you are going to process this person going forward. If you see someone, and I'm going to say a triggering word, so gird your loins. If you see someone, say in a courtroom, and you're on the jury and someone says, well, yeah, Todd, the defendant, he a junkie, but he cool. Like he's the best mechanic in Baltimore City, and he's Baltimore. Well, now the folks who heard that term, the J word, they are more likely to deal out a harsher, more punitive sentence, because now the negative connotation is already associated with Tony. Okay? So a public perception study, the term abuse has been found to have a high association with negative judgments and punishments. Health professionals' negative attitudes found to negatively affect quality of care and ensuing treatment and outcomes. Shame and concerns about social, economic, and legal consequences of disclosing a substance use disorder may prevent folks in seeking help. And I want to change the word may to most definitely, unless someone's dying. And even then, it may not happen, right? Because the shame, the look, or just to even admit that you've used a substance, but you need help because you broke your leg. Like, your leg is broken. You should not be concerned about saying, oh, hey, yeah, I broke my leg because I was skateboarding and I was a little high on coke. Thought I was invincible. I was not. You should not be afraid in an emergency to say something. Case in point, I like to use real world examples from my life. Recently, I was on a flight. I was about to go on a connecting flight. I walked off plane 1, headed to plane 2, and went down like Frasier on the jetway. Just boom, passed out. They get me in a wheelchair. They take me to the bathroom because they got to check me out, paramedics. And they're like, hey, are you okay? What's going on? Da, 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 da. And I was like, hey, yeah, no, I took way too many edibles, too many gummies, and my body short circuited, and I ate pavement, right? By the way, did I mention I was in Texas? I was in Texas. So I come home and I tell my friends, I got really high, got really baked, and I ate pavement and, whatever. And so in sharing my story, all of my friends and family could say, did you tell them that you used pot? Like, did you tell them that it was cannabis? Did you tell? Yes, I told them. They needed to know why I ate pavement. Now, granted, it was cannabis, and the world, our nation seems to be changing again around cannabis, but each state has its own laws. And so the fear was very real. People were like, weren't you scared? And I'm like, old me probably would have been. New me is like, screw it. If you're not going to help me because I did some pot and I almost cracked my skull, like, that's not a me issue. That's a you issue. So, when I say the fear and the shame and the concerns about seeking help for something as what right now, this resurgence that's happening in our nation, where cannabis is seen as innocuous now or low level, my friends, and these are people I'm talking like, PhD folks, are you sure? You shouldn't have told them that. That's going to come back. What about your health insurance? What about your job? For pot. This is the real world we live in. Imagine if I had said that exact same story, but what was in my system was cocaine or heroin or methamphetamines or alcohol, for that matter, a copious amount of alcohol. That is what our people deal with every day. Someone could pass out right now and have a traumatic head injury or a concussion and not go to the doctor because they fell or passed out with substances in their system, and they are afraid and ashamed of how they're going to be judged. So I say all that to say, choose your words wisely. To the left, we see a lot of pejorative and stigma affirming terms. One I used earlier today, which I was making a point, is not something that I use. But to counteract that, we have people or person in active use, person who injects drugs or PWID, person who uses drugs, PWUD, which is all encompassing. That could go for someone who injects drugs or who does not, the PWUD, that is. Or you could say person with substance use disorder, person with alcohol use disorder, person in recovery, person who previously used drugs. These are all person affirming words, statements, phrases, using to describe a person. And in these ways, you can add a person's name in a way that makes it so that you are seeing them and that whatever they do or whatever they did is second, as opposed to saying the words on the left. And that's how we were describing Jackie earlier, right? It was something Jackie. Yep. A person with chaotic use with alcohol or substances. So that may be and that would cover someone who, or go for someone who maybe has not been officially diagnosed with a substance use disorder, but their use has been chaotic, meaning they are experiencing consequences that are detrimental to their way of life, and yet are still engaging in that activity, right? So, other words that can be used for substance use that are stigma affirming and behavior affirming. These I will say out loud on the left. So clean, dirty in relation to objects or drug abuse or addiction or relapse, or clean in relation to a person. So those are all stigma affirming words. Behavior affirming, when we're talking about an object, instead of saying clean or dirty, say sterile, because that is the correct term. Or you use the word used or non-sterile. Instead of drug abuse, substance use disorder. Instead of relapse, try reinitiation to use or reoccurrence of drug use. And unless someone has not bathed, never refer to someone as clean or dirty when it comes to substance use. People are only clean or dirty if they have not engaged in hygiene. They are not clean or dirty because they used a substance. What we would say is that that person is in recovery or abstinent, or that person is currently using or has reinitiated use, right? People who use drugs are not dirty, and they are not magically cleaned because they stopped using. When you say someone is dirty or clean in that way, you are stigmatizing them, because what are dirty things? Dirty things are bad. Dirty people, outside of just hygiene in that sense, dirty people are bad. So when you say someone is dirty, you are calling them bad and you are setting them apart in that way. So this is going to be a little difficult to read in your slides. It'll be a little bit easier. There'll be links and there'll be an actual table and chart. And some of these words, these person-centered languages, the next two slides are for person-centered language in different settings or occupational settings. So in the middle here in blue, we have from recovery dialects. We have a list. Now, there are certain stigmatizing terms that I have mentioned today and that you have seen, that there are specific places where they are deemed acceptable, right? Those places are mutual aid meetings. So thinking NA, SA, GA, AA. So all of the anonymouses or the anonymi. That is where you will hear both people in the participants or your facilitator using the words, "Hi, my name is John and I am an addict. Hi, my name is Jackie and I'm an alcoholic," or "I relapsed," or, you know, "I pissed dirty," right? Because in those closed door meetings, that is the place to unmask and to use the words that you have available, right? It's like when you're talking to your friends, you know, or with your siblings. Y'all can say it, but somebody on the outside, no, 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 no. That's not okay. In that safe space is where these words can be used. When we are in medical settings, when we're talking to journalists, when we're in public, when we're in any of those things, anything outside of those mutual aid type situations and meetings, person-centered language only. And if you are facilitating these things, if a person is in front of you exhibiting substance use or coming to you for substance use treatment, and they call themselves some of those stigmatizing language, you can say, "I'm not going to call you that, but if that is how you would like to refer to yourself, that is you." You continue to use person first language or person centered language because you are trying to lead by example. And so in these slides, we have terminology and words for folks in the healthcare profession, in school settings, in recovery programs, just to give you an idea of some of the affirming and negative languages that you may be seeing in your particular line of work. So here are more. And some of these you can use in your day-to-day. I hope that you do. There are some in here based talking about race and mental disorders, weight, people's weight, people's motivation, parent styles or barriers with parenting, all of these things, right? People may use these. You may have used these, or you may have heard colleagues use them. Here are some alternatives that are strength-based and person-centered to add to your vocabulary and to release the stigmatizing language from their mental confines. Just let them float off into the ether. So some of these things are easier said than done, right? When you are talking to someone and you have them in front of you, or if you're on the phone or in a virtual setting like we are right now, things to remember: your phrasing, consider your tone, your body language, consider your assumptions about what you think about that person, what that person thinks about you, and what they're getting into. Consider the frustration or the personal triggers that may be coming towards you or you might be seeing. People, the tone of voice, the phrasing you use, the body language, all of that, those are all like subconscious cues that people are taking in and that you are sending out. So try to be mindful of that. And if you are unsure, if you are feeling like, you know what, I want to help, but I have no idea if I am saying or doing the right thing, go back to the basics. Respect, compassion, dignity, and non-judgment. We are humans, correct? We are humans. The government hasn't come out and officially said we're aliens yet, but I mean, tomorrow's Friday, maybe Monday. But in general, we're all humans. And so we are going to make mistakes and know that that is okay. However, learn from your mistakes, correct your mistakes, ask questions if you're feeling uneasy. And if you feel like you're in a position where you cannot do that, then again, go back to your basics and treat people how you want to be treated. If you are a person with 0 ACEs and have 0, you've never smoked, you have never done any sort of drugs, you've never had any sort of drink, you've never had any sort of suicide attempt or ideation or any of those things, if you are a complete blank slate of a human, treat the person in front of you the same way you would want to be treated. That is what my whole job is, folks, is to train others how to treat people, like real people, not shells of people, not parts of people, not pieces of people, whole people. That's the job. That's it. That's how I describe my job to people. If you ever met my dad, he'd tell you the same. So, challenging stigma in your organization. What does that look like? We've talked about the language. We've talked about relationships. Be honest. Be authentic. You can do that individually. Just like now, if there is something, if one of you asks me a question and I don't know, I'm not going to BS you. I will tell you I don't know and let me get back to you. That is honesty and being authentic, because I'm a human and I don't know everything. Keep working on your education and personal development, coming to trainings like this, talking to people in your community, talking to the people in front of you and really hearing them and understanding them. On an organizational level, you guys are already starting it. You're doing training and education on a massive level for your organization, for your folks. Provide outlets for feedback, not just feedback of your staff, but feedback from your participants, and actually use it to form your policies and procedures. That doesn't mean you're going to be able to give them everything, because some of us are grant funded or some of us have constraints. Trust me, if BHSB could give me the $1 million I asked for, it would be great, but they can't. That was my feedback last time. But helping to facilitate the feedback process through community advisory boards and participant feedback surveys, or even just an anonymous box to drop things in. Excellent. Like, it helps to inform just the slightest things. Assessment of practices. These things help to assess your practice. Find out if what you're doing is actually working for the people you're trying to serve. And hire people with lived and current using history. Because who better to tell you than them? Them. They do it. And they understand the people that you're trying to serve in a way that you may never. Gotcha. Lastly, on a community level, be active. Have participant advisory boards, awareness campaigns, policy and advocacy. When it's time to stomp the hill for your people. Come to events, and not just events where you can, where it's specifically based on something. If the church is having an event in your community, show up, be a part of that event. It may have nothing to do with what you're offering, but showing that you're a part of the community and that you can be a trusted member of the community is crucial. So, challenging stigma is a daily practice. Every interaction, no matter How small is an opportunity to stop the stigma of drug use? Be mindful of speech, body language, and tone of voice. Ask permission. Can I touch you? Can we talk about this? Can I check this? Are you okay? Are you feeling triggered? Be as transparent as possible. Take grievances seriously. And above all else, which is really weird that I put it at the bottom, but dignity, respect, compassion, and non-judgment. And it's really at the bottom because it is the bedrock of all of your communications with people. So this is what some of these things of challenging stigma can look like organizationally. And I'm going to speed through this so that we can get to questions because we're running out of time. Assessment of your practices. Are you hiring people who use drugs? And if not, why not? And how can we change that? What does it look like? And we are done. I'm going to stop sharing my screen. I know that was abrupt, but I wanted to give you all time for questions. And if I kept talking, we wouldn't be able to do so.
Thank you, Mira. That was another great one.
Thank you.
Even without the videos.
Even without the videos. I know. Okay, now I can't figure out how to stop sharing my screen because I feel like if I hit stop, it's going to stop the recording.
It won't stop the recording, so you can hit stop.
Okay.
Okay, great. Thanks. I was panicking, Rebecca. I was panicking. Okay, so questions, comments. The floor is open. We have 11 minutes.
Well, Aaron put a nice little comment in the chat for you. I don't know if you saw it.
Aaron, thank you. Thank you. I'm looking at some of the comments. Let's see.
Another great comment in the chat.
Well, let me tell you, Allie, first things first, chocolate cake for everyone is the basis of my platform. It's a unifying thing. And if you don't like chocolate, I'll find a different thing that you might want, but cake for everyone. Let's see. So how would you deal with, I'm going back, I see Morgan had a question. So how would you deal with abuse of frontline staff? Abuse from a place of trauma is still trauma. That is correct. When you are facing someone who is in front of you who is being abusive to you, you do stop that disrespect, that trauma, that abuse to you, because you're a human being and you're not a whipping post. But once the situation has been de-escalated, and it may not be you who in that moment can de-escalate or rectify the situation, but afterwards, talking to the person who was aggressive towards you and finding out why they were so aggressive, what happened, having your supervisory staff debrief with you how you're feeling about the situation, how you want to proceed, and see if there's a way forward. You may not be able to work with that person again. Maybe that person will come back in and give you an apology. Hey, I was having a bad day. But both parties need to be addressed, because you're right. You are human. You are not a whipping post just because this is your job. Let's see. Question. What is a non-stigmatizing phrase for red flag, i.e., as a provider, you should take notice of a sign or symptom when expressed by a client? I'm going to have to think about that, because I would need to think about, I would want to talk to you a little bit more about how it's being used? Is it being written in someone's chart? Is it being, just said between colleagues? I would want to kind of talk to you a little bit about that.
What about maladaptive coping mechanism?
True.
Or
Yeah, no, that's
Stigmatizing.
actually a good one.
Just a coping mechanism that's not working, a reaction that's not working or effective.
Correct. Or you could say someone, if it's someone who is, if you know their past, like, hey, this person may have trauma triggers, and just be wary of this topic, or this topic, or touching here, and here, if that's something that you know. Question, can I talk about barriers people face advocating for hiring people who use drugs and any tips for overcoming those barriers? So, Rebecca, it depends on your organization. Some barriers are drug testing. Is the drug testing needed? Why? Why is the drug testing there? What does it do? Is that something that can be eliminated? If it's something that can't be eliminated, what is the organizational threshold for termination due to a positive urinalysis, right? And what's the flexibility on that? Can somebody go to treatment and still remain to have their job? So on and so forth. Thinking through those things can help to advocate more to your higher ups. It may be something that you can't do, but you can advocate for. Do you have any recommendations for stigmatizing terms to describe drugs in educational materials? We struggle with terms like street drugs, recreational, illegal, prescription. So the basic is licit and illicit. So licit equals like prescription. Illicit, which is synonymous with street drugs. And let's see. Aaron said more between colleagues in regards to the red flags. If a client shares these symptoms or you notice these signs, then the combination is a red flag for further screening. So if you were in this sense, if you are talking colleague to colleague, this may be a term that, much like the mutual aid meetings, as long as you are in private, may be able to say, hey, Jim, patient in bed 1 is showing red flags for sexual trauma and possible domestic violence. Tread carefully. They are agitated, such and such. You may be able to use it like that, because not only can the patient not hear you describe them or describe the situation. Well, first of all, you're not describing the patient as a red flag. You're describing their symptoms, their traits, their trauma response as a red flag. And as long as they can't hear it and interpret that you are interpreting them themselves as a red flag, in that mutual aid tone of solace, you may be able to say between colleague to colleague, you may be able to use that. That's one way it could be used. Carla asked, any thoughts on how to manage patient perceptions of judgment or bias from providers and staff regarding drug use and or mental health status? So that is a high hill to climb, and it will take time to build trust, because people have been severely impacted by the structural stigma that surrounds coming in for treatment. Exactly. And it is, unfortunately, Carla, it is your burden to bear to build that trust. It is my burden to bear to help you find the tools to build that trust, right? Being transparent, honest with people, and trying to alleviate fears up front, saying, hey, look, my office is a no judgment zone. I don't care if you use drugs. I don't care if you are what the Gray's Anatomy has defined as promiscuous. That's none of my business. My business is to help you. I don't judge you. I need to ask you these questions so that I can better help you. But I don't think anything negatively of you due to what you do. I don't think negatively of you, period, but especially not because of the activities you do. I just need to know these things to better help you. Again, easier said than done. And unfortunately, that's what I have for you. You have to build that rapport, and you may not always have the time and space that is needed, but constantly showing compassion is key. Well, I've run almost over, and I am so sorry, but I want to thank you all for coming to both sessions, and for having me for your Harm Reduction 101 and for the Stigma training. I hope you all have a wonderful day. And since we are one day closer to the weekend, happy weekend, everyone. Happy early Friday is what I will say. So thank you so much.
Thanks for watching. This video was produced by the network of the National Library of Medicine. Select the circular channel icon to subscribe to our channel, or select a video thumbnail to watch another video from the channel.